Good day, interns. This will be a discussion on the microscopic examination of urine. So for microscopic examination, it includes red blood cells, white blood cells, epithelial cells, casts, bacteria, yeast, parasites, mucus, spermatozoa, crystals, and artifacts. They are considered to be normal unless present in very high amounts. For sediment preparation, a midstream clean catch specimen minimizes external contamination of the sediment, while a dilute random specimen may cause false negative readings. The recommended specimen volume is 10 to 15 ml, while 12 ml of volume is frequently used, because the parameter of the reagent strips are easily immersed in this kind of volume. If 12 ml is not possible, volume should be noted. Next, for centrifugation, it's usually performed at 5 minutes of 400 RCF. And to correct for differences in the diameter of centrifuge heads, we use RCF is equivalent to 1.118 times 10 minus 5 multiplied by the radius in centimeters times RPM2. The use of braking mechanism causes a disruption of the sediment. So for the volume we usually use for sediment examination, it's 0.5 to 1 ml. And for the concentration factor, it is computed as the volume of urine centrifuge divided by the sediment of volume. So for the recommended or like the average volume of urine that is usually used, it's 12 divided by the sediment volume of 0.5, so the concentration factor would be 24. And for the volume of the sediment examined, it's 20 UL or 0.02 ml, covered by a 22 by 22 mm glass cover slip. Next, to examine the sediment, we usually use a minimum of 10 fields under low and high power. And for LPO, this usually is used to detect casts and to ascertain the general sediment composition. And HPO is used to identify casts. To examine sediments, always remember to reduce light because many sediment constituents have similar refractive index such as urine. To report sediments, casts are usually reported in an average number per LPF, and for RBCs and WBCs is the average number per 10 high power fields, and for epithelial cells, crystals, and other elements, we use the reporting of rare, few, moderate, many, or 1+, 2+, 3+, and 4+. Next, for the sediment stains, first is Sternheimer-Malbin, and the composition of this stain is crystal violet and safranin O. Its action is it delineates structure and contrasting colors of the nucleus and cytoplasm. Its function is to identify WBCs, epithelial cells, and casts. The next stain is Toluidine blue. Its action is to enhance nuclear detail, and its function is to differentiate WBCs and renal tubular epithelial cells, examination of cells from other body fluids. Next is 2% acetic acid, which lyses RBCs and enhances the nuclei of WBCs, and it distinguishes RBCs from WBCs, yeasts, and oil droplets, and crystals. For the lipid stains, we have oil red O and Sudan 3. They act as stains for triglycerides and neutral fats, and they do not stain cholesterol. They function to identify free fat droplets and lipid-containing cells and crystals. Next, for gram stain, its action is to stain bacterial casts, which are easily confused with granular casts, and the function of a gram stain is to differentiate between gram-positive and gram-negative bacteria. Next, for Hansel stain, it contains methylene blue and ASNY, which stains eosinophilic granules and is used to identify urinary eosinophils. For Prussian blue, it is used to stain structures that contain iron, and its function is to identify yellow-brown granules of hemosiderin in cells and casts. Next, we go to the types of microscope. So first, the most common, bright field microscope. It is used for routine urinalysis. Second, the phase contrast microscope, which enhances the visualization of elements with low refractive indices, such as hyaline casts, mixed cellular casts, and mucus threads. And it is also used for trichomonas. And for the polarizing microscope, this aids in the identification of cholesterol in oval fat bodies, fatty casts, and crystals. The next type of microscope is the dark field microscope, and this aids in the identification of Treponema pallidum. Next is the fluorescence microscope, which allows visualization of naturally fluorescent microorganisms or those stained by a fluorescent dye, including labeled antigens and antibodies. For the interference contrast microscope, this produces a three-dimensional microscopy image and layer-by-layer imaging of a specimen. Next, we will discuss the urine sediments. They contain a variety of formed elements, and urine sediment preparation methods determine the actual concentration of the sediment and number of elements present in a microscopic field. The first sediment that we will discuss are the red blood cells. They appear as non-nucleated biconcave discs. They could be crenated in hypertonic urine, and they could look like ghost cells in hypotonic urine, and they may be dysmorphic with glomerular membrane damage. For the sources of identification error, they can usually be mistaken for yeast cells, oil droplets, or air bubbles. For the reporting of RBCs, which we mentioned earlier, is the average number per 10 high-power fields. Their clinical significance pertains to the damage in glomerular membrane and vascular injury in the genitourinary tract. Next urine sediment would be the white blood cells. They appear larger than RBCs. They are granulated, multi-lobed neutrophils, and they could be seen as glitter cells in hypotonic urine, but they have no pathologic significance, and for mononuclear cells with abundant cytoplasm. Sources of identification error would be renal tubular epithelial cells, and the reporting is the same with RBCs, which is the average number per 10 high-power fields. Their clinical significance would pertain to drug-induced interstitial nephritis, UTI, renal transplant rejections, or bacterial infections such as in pyelonephritis, cystitis, prostatitis, and urethritis. Next, for the epithelial cells, they are usually squamous and they appear as the largest cells in the sediment with abundant irregular cytoplasm, and they have prominent nuclei. For sources of error, they are rarely encountered and they could be mistaken as folded cells which may resemble casts. Take note that squamous cells can serve as a good reference when examining urine under the microscope. For reporting, they could be reported as rare, few, moderate, or many per low power field, or HPF, depending on the lab protocols. The clinical significance of epithelial cells are when they become Ku cells, which are indication of vaginal infection by Gardnerella vaginalis. Epithelial cells could also be transitional cells, which appear as spherical, polyhedral, or caudate with a centrally located nucleus. Their sources of error would be the spherical forms that resemble renal tubular epithelial cells, and they are reported as rare, few, moderate, or many per high power field. Their clinical significance would be the syncytia, which is the increased number of transitional cells, which could appear in singly or in pairs, and they follow invasive urologic procedures, but they have no significance. In malignancy or viral infection, if morphology is abnormal with vacuoles or irregular nuclei. Next are the renal tubular epithelial cells. They are the most clinically significant epithelial cells found in urine, and they appear as rectangular, columnar, round, oval, or cuboidal with an eccentric nucleus. They are possibly bilirubin stained or hemosiderin laden. The sources of error for RTE cells are the spherical transitional cells and or granular casts. They are reported as an average number per 10 high power fields, and their clinical significance would be of necrosis of the renal tubules or secondary effects of glomerular disorders. They could be also seen following hemoglobinuria and reticular and renal tubular epithelial cells may contain yellow-brown hemosiderin granules which could be stained by Prussian blue stain. Renal fragments are indication of severe tubular injury with basement membrane disruption. Next are the oval fat bodies. They are basically lipid-containing RTE cells, and they are seen in conjunction with free-floating fat droplets. They appear as highly refractile RTE cells, and their sources of error confirm with fat stains and polarized microscopy. For starch and crystal particles, they are also capable of polarizing light, and for vaginal preparations and lubricants, which are considered when free-floating fat droplets are present, and fat-laden histiocytes can be differentiated from oval fat bodies as they are larger. Oval fat bodies are reported as an average number per 10 high-power fields, and their clinical significance is seen in lipiduria, in glomerular damage caused by nephrotic syndrome, in severe tubular necrosis, and diabetes mellitus. Next urine sediment would be bacteria. They appear as small, spherical, and rod-shaped structures, and their sources of error are amorphous phosphates and urates. They are reported as few, moderate, or many per high power fields, and the presence of WBCs may be required. Their clinical significance could be seen in lower or upper urinary tract infection. Take note that Enterobacteriaceae gram-negative rods, or coccyx-shaped staph, and Enterococcus are also capable of causing UTI, but actual bacteria causing UTI cannot be identified with microscopic examination. Next are the yeasts. They appear as small oval refractile structures with buds and/or mycelia. Their sources of error, because they would be mistaken for RBCs, they are reported as rare, few, moderate, or many per high power field, and also the presence of WBCs may be required. Their clinical significance could be seen in Candida albicans in diabetic patients, immunocompromised patients, and women with vaginal monoliasis. For parasites seen in urine sediments would be Trichomonas trophozoite. They appear as pear-shaped, motile, flagellated, and their sources of error are WBCs, renal tubular epithelial cells, and they are reported as rare, few, moderate, or many per high power field. The clinical significance can be seen in sexually transmitted T. vaginalis infection, and infection of the male urethra and prostate is usually asymptomatic. Next urine sediment would be Spermatozoa. They appear as tapered oval head with long, thin tail, and they do not have sources of error because they are usually easy to identify, and their reporting is rare, few, moderate, or many per low power field. They usually have a rare clinical significance, but in cases of male infertility or retrograde ejaculation, in which the sperm is expelled into the bladder instead of the urethra. They are usually found in urine of both men and women following intercourse, masturbation, or nocturnal emissions. Next, for mucus, uromodulin is a major constituent of mucus and more frequently present in female urine specimens. They appear as single or clumped threads with low refractive index, and their sources of error are hyaline casts. They are reported as rare, few, moderate, or many per low power field, and they have no clinical significance in both male and female. Next, we will discuss urine casts. They are the only elements in the urine sediment that are unique to the kidney. We use low power objective to detect the presence of casts, and for high power, we use this objective to identify the type of cast. Urine casts usually have low refractive index, and they dissolve quickly in alkaline urine. For their composition and their formation, uromodulin is the major constituent. They are formed in the distal convoluted tubules and collecting ducts. Cylindroids, which are cast structures formed at the junction of the ascending loop of Henle and distal convoluted tubule. Cylinduria is the presence of urinary casts. Increased urinary protein, frequently associated with the presence of casts, is caused by underlying renal conditions. The most frequently seen casts are the hyaline casts. They are pink in Sternheimer-Malbin because they are made up of entirely uromodulin. Normal causes of hyaline casts would be strenuous exercise, dehydration, heat exposure, and emotional stress. They are usually seen as colorless, homogeneous matrix, and their sources of error are mucus fibers, hair, and increased lighting. They are reported as an average number per low power field, and their clinical significance could be seen in glomerulonephritis, pyelonephritis, chronic renal disease, congestive heart failure, stress, and exercise. While the presence of RBCs in urine may indicate bleeding, the presence of RBC casts are more specific. Normal cause of RBC casts would be strenuous contact sport, and for pathologic causes would be primarily of glomerulonephritis. They appear as orange-red color, cast matrix containing RBCs, and their sources of error would be RBC clumps. They are reported as an average number per low power field. Their clinical significance could be seen in glomerulonephritis and strenuous exercise. They may also be present in acute tubular necrosis, but must be present in conjunction with other pathologic findings such as RTE cells and a positive reagent strip for blood. Next are the WBC casts, which are primary markers for distinguishing pyelonephritis, which is upper UTI, from cystitis, which is lower UTI. They appear as granular, which owes it to the neutrophils in the matrix, and eosinophil casts may also be present in appropriately stained specimens. Usually, WBC casts are cast matrix containing WBCs, and their source of error would be WBC clumps. They are reported as an average number per low power field, and their clinical significance could be seen in pyelonephritis and acute interstitial nephritis. Next are the bacterial casts. They appear as bacilli bound to protein matrix. Their sources of error are granular casts, and they are reported as an average number per LPF. Their clinical significance are found in pyelonephritis. This cast may be pure or mixed with WBCs, and they can be confirmed using gram stain. For epithelial cell casts, they appear as RTE cells attached to protein matrix. Their sources of error are the WBC casts, and they are reported as an average number per LPF. Their clinical significance can be found in renal tubular damage, and the possible causes of tubular destruction are heavy metal and chemical or drug-induced toxicity, viral infections, and allograft rejection. They are accommodated by WBC casts in pyelonephritis. Next are the granular casts. These casts occur as a result of cellular disintegration of cellular casts and tubule cells or protein aggregates filtered by the glomerulus. Other than strenuous exercise, granular casts may form from lysosomes that are normally excreted by RTE cells. They appear as coarse and fine granules in a cast matrix, and their sources of error are clumps of small crystals and columnar RTE cells. They are also reported as an average number per LPF, and they can be seen in glomerular nephritis and pyelonephritis. The next type of casts are the waxy casts. They appear as highly refractile casts with jagged edges and notches, and their sources of error are fibers and fecal material. They are reported as an average number per LPF, and their clinical significance is stasis of urine flow and chronic renal failure. Waxy casts are usually seen in conjunction with other casts associated with a condition that caused the renal failure. They are also from degeneration of hyaline cast matrix and any cellular elements or granules contained in the matrix. For fatty casts, these fats do not stain with Sternheimer-Malbin, and they are confirmed using polarized microscopy and Sudan 3 or oil red O. They appear as fat droplets and oval fat bodies attached to protein matrix, and their sources of error are fecal debris. They are reported as an average number per LPF, and their clinical significance could be seen in nephrotic syndrome, toxic tubular necrosis, diabetes mellitus, and crush injuries. Broadcasts are the type of casts that are also called renal failure casts, and all casts may appear in a broad form. The most common are granular and waxy casts. These casts appear wider than normal cast matrix, and their sources of error are fecal material and fibers. They are also reported as an average number per LPF, and their clinical significance could be seen in extreme urine stasis and renal failure. For mixed cellular casts, these are difficult to identify, but staining or face microscopy aids in their identification. When mixed casts are present, there should also be homogeneous casts of at least one of the cell types, and they will be the primary diagnostic marker. Mixed cellular casts appear as presence of mixed elements, and their clinical significance could be found in glomerulonephritis, which have a predominant cast of RBCs, and in pyelonephritis, which will have predominant WBC casts. The next part of urine sediment examination would be the urinary crystals. They may appear as true geometrically formed structures or as amorphous material, and they are rarely of clinical significance. The reason for identification of these crystals is to detect the few abnormal types, and they are all reported as few, rare, moderate, or many per high power field. Crystals are formed through the precipitation of urine solutes, and the factors that affect their solubility are temperature, solute concentration, and pH. The majority of crystals are in specimens that remained at room temperature or are refrigerated prior to testing. Specimens that show high specific gravity of crystals are present in freshly voided urine. First of the normal urinary crystals is uric acid. This type of crystal is usually seen in acidic urine of less than 5.5 pH, and the color of this crystal is yellow-brown. They also appear as rosettes, wedges, rhombic, or four-sided flat plates. These type of crystals get confused with cystine crystals. They are highly birefringent in polarized light, and they are increased levels usually associated in increased levels of purines and nucleic acids, like in patients with leukemia receiving chemo, patients with Lesch-Nyhan syndrome, and sometimes in patients with gout. Next are the amorphous urates, which are also seen in acidic urine of a greater than 5.5 pH, but they revert back to uric acid upon acidification. They have a color of brick dust or yellow-brown, and they appear as pink precipitates on refrigerated specimens. The next type of crystals are the calcium oxalate. They are frequently found in acidic pH, but may also be seen in neutral pH and rarely in alkaline urine. The both forms of calcium oxalate are birefringent. They are sometimes seen in clumps attached to mucous strands, and they may also resemble casts. They are colorless and appear as envelopes, oval or dumbbell shaped. The two forms, namely dihydrate and monohydrate. For dihydrate, they are colorless octahedral envelope or two pyramids joined at their bases, and this is the most common form. For monohydrate, which is oval or dumbbell shaped, which is the less frequently seen form. Next crystal are the acid urates. This type of crystal is rarely encountered, and it is also seen in less acidic urine like amorphous urates. They are usually seen in conjunction with amorphous urates. Their color is yellow-brown, and they have an appearance of spicules similar to ammonium biurate, but they have larger granules than ammonium biurate. Next crystal is sodium urates. It can be found in acidic urine, and it appears needle-shaped. Another form is monosodium urates, which appear pencil-shaped. Next is amorphous phosphates. They can be found in alkaline urine and sometimes in neutral urine. For color, they appear white to colorless, and they can be white precipitates following refrigeration. Next crystal is the calcium phosphate. It can be found in the pH of alkaline or neutral, and they are colorless and appear flat, rectangular plates or thin prisms. They are also often found in rosette formations. These can also be confused with sulfonamide crystals, but calcium phosphate dissolves in dilute acetic acid while sulfonamides do not. Next, the triple phosphate, they have a feathery appearance when they disintegrate, and they are birefringent under polarized light. They are seen in urine associated with the presence of urea-splitting bacteria, and they are also found in alkaline pH. They are colorless, and they have a coffin lid appearance. Next, ammonium biurate crystals resemble urates in that they dissolve at 60 degrees Celsius and convert to uric acid crystals when glacial acetic acid is added. They are also encountered in old specimens. They can be found in an alkaline pH. They have a yellow-brown color, and they appear like thorny apples. Next crystal, calcium carbonate. They form clumps that resemble amorphous material and can be distinguished by the formation of gas after the addition of acetic acid. They are also birefringent. They appear in alkaline urine. They are colorless and have a dumbbell or spherical shape. So now we will discuss abnormal urinary crystals. So first, for cystine, it appears in acidic pH. It is colorless and appear as hexagonal plates. The disorder that is associated is inherited cystinuria. It's a metabolic disorder that prevents the reabsorption of cystine by the renal tubules, and these crystals may be thick or thin. Only thick cystine are able to polarize light, and to confirm using cyanide nitroprusside test. Next crystal is cholesterol. This is associated with disorders producing lipiduria. It is also seen in conjunction with fatty acids and oval fat bodies, and this crystal is highly birefringent. It can be seen in acidic urine. It is colorless, and it appears as notched plates. The disorder associated is nephrotic syndrome. Next, for leucine, it can be seen in acidic pH or neutral pH. It has a color of yellow-brown, and it appears as spheres that demonstrate concentric circles and radial striations. The disorder associated is also nephrotic syndrome. Next, for tyrosine, it can be seen in acidic or neutral pH. It is colorless to yellow, and it appears as needles that frequently form clumps or rosettes, and the disorder associated is liver disease. It is usually in conjunction with leucine crystals in specimens with positive chemical tests for bilirubin, and it may also be encountered in inherited disorders of amino acid metabolism. Next, bilirubin crystals. They are found in disorders that produce renal tubular damage, such as in viral hepatitis, and bilirubin crystals may be found incorporated into the matrix of the casts. They appear in acidic pH, they are yellow, and they can be seen as clumped needles or granules. The disorder associated is liver disease. Next are the sulfonamide crystals. They are common in patients being treated for UTI, and the primary cause of sulfonamide crystallization is inadequate patient hydration. If present in fresh urine, it can be suggestive of tubular damage. It is found in acidic or neutral pH. It has a varied color of colorless to yellow to brown, and its appearance is also varied, but the most common appearance is needle, rhombic, whetstones, sheaves of wheat, and rosettes. The disorder associated is infection treatment. Next is the radiographic dye. It has a similar appearance to cholesterol, and it is also highly birefringent. It is accompanied by other lipid elements and heavy proteinuria. Specific gravity is markedly increased when these crystals are present. It can be found in acid urine. It is colorless and could appear as flat plates. The disorder associated is radiographic procedure. The next abnormal urinary crystal is ampicillin. It is not frequently encountered, but it can be seen following massive doses of penicillin without adequate hydration. It is seen in acidic or neutral pH. They are colorless, and they could appear as needles. The disorder associated is infection treatment. Lastly, we will discuss urinary sediment artifacts. They are found particularly in specimens collected under improper conditions or specimens that have dirty containers. Common artifacts are starch, which resemble fat droplets when polarized and can be confused with RBCs. Also, oil droplets and air bubbles, they also resemble RBCs, They may result from contamination by immersion of oils or lotions and creams and may be seen with fecal contamination. Next is pollen. They appear as spheres with cell walls and occasional concentric circles. Pollen grains are seasonal contaminants. For hair and fibers, they are initially mistaken for casts, but they are larger and more refractile. And fecal contamination appear as plant and meat fibers like brown amorphous material.